lucky to welcome special guest Kristen Sherlin. Now, Kristen is a pharmacist at UNC Health Blue Ridge. And the reason she's joining us today, pharmacist, author on the New England Journal of Medicine publication, Ketamine or Etomidate for Tracheal Intubation of Critically Ill Adults, aka the RSI trial. Kristen, welcome. Thanks for joining. How are things going?
Thanks for having me, Nick. Things are great. Happy to be here. Happy it's Friday, ready to get the weekend started, but this is a pretty good way to kick it off.
You said it, right? Friday rolling today, great vibes. And this is a bonus episode, right, for the RSI trial. So if you're a listener and you haven't listened to the full episode where we sort of dive into the nitty gritty with the trial author, with the trial itself, senior author Matt Semler and RSI guideline chair Nicola Quisto, please do that. But there's so much to go into in that. Can't cover everything I wanted to talk about. So even better, Kristen, thank you so much for joining us. I want to dive into a pharmacist perspective on sort of being involved in a pragmatic trial like this, because I think especially for early practitioners, things you're reading this, but I think sometimes putting yourself in the researcher's perspective can sort of give you a little different twist on how incredible that this sort of trial and trials like this get done. But we have to get you on record first. So going into this study, what was your preferred RSI sedative or combination sedative paralytic that you like to use?
I was definitely team ketamine. I think
Yeah.
a lot of us were. I don't know. It has some great benefits to it, having the pain relief as well as, a little bit longer duration of action compared to etomidate. It just kind of lined up better with your paralytics. But also, just personally, I felt like if this was me in that situation, I would want ketamine. So, yeah, definitely team ketamine. I guess I was a little less favorable on the paralytic. Obviously, there are pretty clear contraindications to succinylcholine. So, kind of got to base it on that. But going in, definitely team ketamine.
And that really, because you're EM trained, correct? So like it feels like a lot of the EM sort of side of things was really team ketamine, and it felt like more of the critical care side of things was etomidate. I'm not saying that because of the results of the trial, but that's when you hear people talk about their preferences, that felt like how it was kind of split a little bit.
Yeah, definitely. I'm actually critical care trained, but went into critical care residency always kind of wanting to do EM, knowing that was where I wanted to end up. So definitely, more focused on that and immediately started after residency in EM. So kind of converted myself a little bit. But yeah, it is definitely a split. I feel like the EM people were very much pro ketamine with the occasional etomidate use, whereas ICU was, I think, more etomidate. But I also think, being EM, a lot of times we don't even have a patient's name, much less any like background history on the patient.
There
So,
a go while you're intubating them,
yeah,
right?
it's like kind of a blind situation that we're going into. So we were just picking an agent based on what we thought was best without really having to consider any patient specific factors like the ICU gets the luxury of. So I think it's a little bit different in that scenario. But yeah, I think most EM people are pretty pro ketamine.
In the words of Frank, you are one of those dang critical care trained EM pharmacists. You're me, that's me as well, right? So
Yeah.
welcome. We're part of a very fun crew here. Now, what kind of research experience did you have prior to this? Because being able to say you're like participating in this like gold standard trial, like are you like a researcher extraordinaire up until this point, or what was your research experience sort of before this?
Absolutely not a researcher extraordinaire. Definitely can't go there. Obviously, all of us that have done residency and been involved in positions that, have residency programs, we're all involved in residency focused research, which is usually retrospective. At Vandy, we're lucky that we had, as the EM team, participated in a couple of prospective clinical trials that kind of, I guess, set the stage for our involvement in this one, specifically the Bougie study. So it was a pretty similar setup, and we did a lot of the data collection for that study as well as the EM pharmacist. So that kind of, provided the pathway for us to be so heavily involved in this trial as well.
Well, and how great is it working with sort of the pragmatic critical care research group, sort of the physician leadership in that I feel like probably makes doing all of this research a little easier.
Yeah, no, they are definitely research extraordinaires. So it's such a pleasure to work with them. They were always happy to answer any of our questions, let us provide feedback about things that were going well, things that weren't going well. Maybe we need to make a little tweak here. So it was definitely great, having those people that you can rely on that really know what they're doing in the world of research, but are also open to your feedback and willing to make changes on what we're seeing as kind of the boots on the ground people.
Now, they let us in on sort of how long the trial itself had sort of been in the works. How long were you involved with the study? Like, is it kind of from day zero or whatever when the protocol's in, or what's the timeline of that look like?
Yeah, it was pretty early on. Dr. Casey came to us as the EM pharmacy group, knowing that we had helped with the Bougie study so much and asked if we would be willing to help with this study as well. To not only kind of, be there as the data collection person if we could, and then also, just be there as the reminder because we were at every intubation and helping to make those decisions about what we're going to use for RSI medication. So, kind of also adding that in of, hey, do you want to randomize this patient? We're doing this study. So, yeah, it was pretty early on. I would say we went on for maybe a year and a half from like that first meeting to kind of wrapping things up with final randomizations. But yeah, it was a decent amount of time. It was a good learning experience.
All right. So for those who, if you've been living under a rock and you're like, wait a second, what is this RSI trial? All right. Let's give a quick 60-second what the RSI trial and overview of it. Again, if you haven't listened, can't emphasize enough to go into the full episode, but pragmatic US multi-center, unblinded, randomized, parallel group trial enrolling adult critically ill patients undergoing tracheal intubation. Key exclusion criteria, those unable to enroll in time or trauma patients, randomized 1-to-1 to ketamine or etomidate, dosing guidance provided but not protocolized, primary outcome 28-day in-hospital mortality, secondary composite outcome, cardiovascular collapse during intubation, things like systolic blood pressure less than 65, new or increasing pressors, or cardiac arrest. Just under 2,400 patients were enrolled and randomized. No difference in that primary outcome of 28-day in hospital mortality, but ketamine significantly increased the risk of the composite secondary outcome driven by a new or increased rate of vasopressors. Okay, so kind of all on the same page. So the study was completed in 6 US hospitals, right? In the ED and the ICU. So from a research perspective, like where was the majority of your involvement? Are you located in are you primarily in one hospital? Are you primarily in one ED? How does that sort of work from a data perspective?
Yeah, so my involvement was just strictly in the Vanderbilt Emergency Department. Obviously, this was going on in our ICU as well, but there's no way we were going to be able to run back and forth between the ED and the ICU. So they kind of had their own people that were involved, and then my involvement was just in the ED.
Now set the scene for us, right? Maybe describe the Vanderbilt ED or in these sort of like moments like this. Are the pharmacists very hands-on, involved? Sort of set the scene so we can maybe get a feel for what that environment is like.
Yeah, so it's busy, as I think most EDs are at this moment in time. Vanderbilt is the stroke center, trauma center, and they accept transfers from everywhere. I think I've seen patients come in from another country. There's never a no really there. So there's always something new, fresh, exciting coming in the door. And yeah, the EM team is very hands-on there. We're at every bedside for any critically ill patient, trauma, stroke, anything you name it, even if it's just something that they want our help with because they're like, I need medication help. We were always happy to help, but also, being hands on, being there with the medications, being the ones that drew up the medications. There were even circumstances where we developed a pharmacist medication administration training program so that we could help administer medications during some of those more critical responses, such as codes. So, anything and everything, we were always willing to do it. And, kind of the same thing with what's coming in the door, patient population wise, you're getting anything and everything. So every day was different, always busy. Sometimes we were getting pulled in multiple directions, but this is one of those unique opportunities that we had to participate in. So, we definitely tried to do our best to be there for these patients throughout the randomization and data collection process as much as we could.
If you're watching on the YouTube right now, you can see we're showing sort of what the protocol looks like. And I want to highlight, right, at the time of the study intervention, the patient will have in the room a physician trained in the care of critically ill adults, a critical care or emergency medicine nurse, and usually a respiratory therapist and pharmacist, right? So clearly, very important getting shouted out in the protocol itself. So definitely wanted to highlight that. Now, obviously, what sort of other pharmacy involvement was there? This is sort of your moment. If there's people, other pharmacists you want to give a shout out to, because obviously, like your name is in that, but yeah, you, Kristen, did not do 100% of everything in this. I can say that probably 100% guaranteed.
Yeah, no, definitely can't work every hour of every day. So not all on me. Honestly, huge shout out to the entire EM pharmacy team at Vanderbilt. Ryan Dillon and Linda McLaughlin specifically, they were kind of the two other pharmacists that were with me throughout this whole process from the very beginning. Attending those meetings initially with Dr. Casey, I just happened to be the lucky one that was there for some of the follow-up meetings and able to kind of, help get us representation on this trial. But yeah, you'll see all of the EM pharmacy team listed there. Montana, Mary, Colton, even Joanna, she's the MICU pharmacist at Vanderbilt. We share an office with her, and she's a legend in and of herself. So
Oh, wait a second. You share an office with Joanna?
yeah, it's kind of wild. So
Okay. Yeah. Yes, we stay in Joanna. Anytime we bring her up, she's the absolute best.
yeah.
Do you have any funny stories? What's it like sharing an office with her? Because like people who don't know her, she's a very fun person. She has a great personality. I imagine
Yeah.
that could be fun. Is she a prankster?
She's not really a prankster, no. But it was great sharing an office with her just because she is so personable. She's so sociable. At first, walking in, I was only a year out of residency when I took the position at Vanderbilt. So it was kind of like a little bit intimidating because you know
Yeah,
how well known she is in
absolutely.
pharmacy and research and how accomplished she is. And just watching that everything she can get done in a day, it was like, okay, I don't know that I'm ever going to be that. But yeah, then you get to know her on a personal level, and she's great. So I definitely, miss sharing an office with her now that I'm back in North Carolina. But we still keep in touch sometimes.
Yeah, she's the absolute best. Kind, awesome, smart, the best. Okay, we could go on and on about Joanna. The real reason RSI trial. Let's divert back here. So, walk us through how screening for enrollment took place and how this process differs from like a standard RSI timeline. Because like what people have to emphasize, like this is already a really short, like it's called rapid sequence intubation. So how do you squeeze in a whole trial enrollment into this?
Yeah, honestly, it was a little easier than you would think, but I think having that practice with the bougie study kind of set us up for success. We had envelopes. Initially, they were just so Vanderbilt. Let me back up. Vanderbilt ED has A pod and B pod. Initially, the envelopes were just an A pod outside of our trauma bays because that's usually where the more critical patients landed. But you know, these days and times they land anywhere and everywhere you can. So that was kind of one of the things that we changed throughout the process was also adding those envelopes into B pod so that we weren't constantly running back and forth and delaying something that's supposed to be rapid. So we would grab an envelope, take it to the room as everybody was setting up for the intubation, kind of starting to discuss what medications they might want to
Wait, quick
use.
pause.
Yeah.
How do you get alerted? Was there like is there like an alert system? Like how? Because like in a ED that busy, there could be three intubations happening you don't even know about.
Yeah, no, there was no specific alert system. I think one of the unique skills you develop as an EM pharmacist is listening out of both ears as well as watching what's going on. So just, being aware of your surroundings, hearing conversations that are happening between other people, knowing, hey, this might be something I'm interested in being at or need to be at. But also, I think the good thing about the relationship between EM pharmacy at Vandy with the providers is they are very good about calling us. We had a cell phone for the team, so they would always call if we weren't lurking around because we'd already somehow heard about this. and be like, hey, we're about to intubate this patient. Can you please come help? So no official alert system, but just constantly being aware, head on a swivel type situation.
Okay, so your spidey senses are activated, right?
Yeah,
So
yeah,
you
we're
go into the room, you're bringing the envelope. All right, continue.
yeah. So we bring the envelope to the room, we start having those conversations about the plan for intubation, and just kind of holding up the envelope, asking, do you guys want to randomize to the RSI trial? If the answer is yes, open the envelope. It was just a one-page sheet. On the back, it showed what you got, ketamine or etomidate, with the dosing recommendation table. And then on the front side were your data collection points that we were filling out throughout the intubation. So it didn't really interrupt things too much. It was pretty quick.
So, I know in an EM environment, people can be sometimes competitive. So did it get to the point where people would try to guess what was going to be, were there like pre envelope polls of like people in the room guessing what it was going to be?
Not necessarily. I mean, I think there were definitely situations in which people were hoping one way or the other. Obviously, we were a very big ketamine driven intubation um,
So it
population.
like so it
So
like hurt your in the beginning, it probably hurt your soul when somebody that you thought was a slam dunk for ketamine is getting etomidate, right?
a little bit, yeah. I mean, I did. So the hospital I did residency at, they used a little more etomidate than I think we were at Vandy when I was there. So I mean, I did have that like, okay, I've seen etomidate work for patients. Like, there's nothing wrong with it. But do I personally like ketamine? Yes. So it did, I think hurt everyone's soul a little bit to occasionally see etomidate, but everybody was pretty open to it. I think, initially there were some struggles specifically in the ED with people wanting to have control over what they were choosing and not wanting to do the study. So, yeah, I mean, that's kind of like, oh, this is taking it completely out of my hands. Like, am I okay with this?
And is that something that do is it just kind of time? Is it education? What is something that gets, because you're right, in medicine, a lot of us are sort of, especially the provide, they can be very they want their controlling is the wrong phrase, but they like things done their way or a certain way sometimes,
Yeah,
right?
luckily, I mean, I feel like going back to the relationship we had with them, like, they were pretty willing to always listen to pharmacy's input on the situation. But there was definitely a component of re education on the study and purpose of the study that really helped kind of boost our numbers and get over that initial hurdle of people, having some hesitation about releasing that control.
And yeah, you mentioned the
Yeah, there you go.
paper that got kind of get pulled up. Yeah, so the dosing chart, and then right above in bold font, that makes sense. It's almost like feels like Deal or No Deal, except it's like instead of like a big briefcase, it's like I'm guessing the big manila envelope there. So
Yeah.
were the medication, since it was unblinded, was there any sort of special storage or anything with the medications, or were they all kept as they normally are, business as usual from getting the drugs themselves?
Yeah, no, business as usual. We have RSI kits that contain, both ketamine, etomidate, as well as all of your paralytics at Vandy. So we would always, anytime we were preparing for an intubation, grab one of those from Omnicell along with the envelope and take it to kind of set up alongside everyone else that was preparing for the intubation.
Now, I know there was the trial itself didn't mandate any differences in post RSI management, but anecdotally, when you're sort of in this research environment, did you feel like anything was different after like RSI or even during it? Or did it really feel like, all right, we chose the agent, now we're putting it in and it's business as usual?
Yeah, no, it was definitely pretty much business as usual. We're there to take care of patients. Like, I'm not gonna, change anything I'm recommending or setting up post intubation just because this person was in the study. Obviously, if they require vasopressors, we're going to get vasopressors, and then we're going to continue on with post intubation sedation as usual. Like, it was pretty much like, I think, a seamless flow. Really, the only additional step was kind of opening that envelope and saying, hey, we're using this as our induction agent.
So one of sort of the limitations or things, right, to an unblinded study, right? You can get the what's called the Florence Nightingale effect, right, where you start to see some of the effects of an intervention and you start to might feel one way or the other. So obviously, you coming in as a pro ketamine person, the results probably definitely surprised you. But did you have any inkling coming up to it that that these were going to be the findings? Were you anecdotally seeing this?
Yeah, I think we definitely already kind of, as an EM team, had this risk of ketamine in mind. Like, we would constantly teach our residents, like, hey, if you've got a septic shock patient that you're about to intubate, go ahead and grab pressors in some form, whether that's push dose pressors or a bag of norepi, because we are seeing this effect where patients that are already catecholamine depleted and then get ketamine do crash post intubation. So I think, we kind of already as a team had that pause going into intubations prior to this study even getting up and running. But I think that was also kind of one of the things that, the physicians were also realizing, and they wanted to investigate this a little bit more as well. So, yeah, I mean, I think we kind of, as a team already had that inkling that things may go this way. But yeah, it's nice to see it confirmed, I guess.
So how has your sort of practice style or preferences changed after the results of these?
Yeah, I still want to say that I'm team ketamine because I
I
don't think
think
that
that's
I can.
allowed.
Yeah, I don't think I can ever give up on it. It might be like my first true love as a medication. But I think it does give you more of a pause in situations when you're recommending an induction agent. Just really taking in all of those patient specific factors that make you want to choose one or the other. At least, now I think the pause that I had in the back of my head has now been confirmed. Like, this is not one size fits all. Every patient's different between their past medical history or current presentation, and you have to factor all of that information that you have in that moment into making the best choice, because it's really, I mean, I hate to say this, but it's kind of an art.
Absolutely.
Yeah, so definitely, more pause, more consideration.
So how cool is this seeing your name on a New England Journal of Medicine article?
I mean, it was pretty wild, actually. It wasn't something I think I ever like thought this would happen to me. This was not necessarily a career goal of mine. Like, like I mentioned earlier, we shared the office with Joanna, who has so many publications, and it's like, yeah, I'm never going to be that. But
Well, it
seeing,
almost feels like this is like you say a goal of New England Journal of Medicine. It almost feels like an unattainable goal, right?
yeah,
As like if you're not actively doing all of these like research or things like that. So it's not like you don't have goals. It just felt like, yeah.
yeah, yeah, like, sure, publications elsewhere that can happen, but like New England Journal of Medicine, yeah, mind blowing on that one. But pretty cool to see it out there. Definitely had some colleagues reach out and say congratulations, what a career accomplishment, and I'm super proud of it. Happy that it's there. Happy that I could contribute. But yeah, it's still a little like mind blowing.
And we got the name highlighted right here. So did you know this is where they were going to be submitting to? Like, was there any discussion within like the bigger research group, or was that kind of more of like a surprise?
Um, I had hope because of this research group that it would be somewhere, decently big. And I was on all of the communications after the study stopped enrolling about manuscript development and publication opportunities. So I did know prior to it actually getting published that this is where it was going. But at the beginning of this, absolutely not. So kind of double-edged sword there. Definitely a surprise, but a pleasant one.
Yeah, that's got to be a top five professional feeling, maybe even top one, right? Seeing that. So cool. Yeah, definitely want to make sure you get your flowers on that because that's unbelievable. Like an accomplishment that very few non-physicians will get to get in their career. So awesome job. Now, huge. You mentioned all the things that you probably learned in this. I'm gonna make you pick one or the other. If you had to say you learned more about conducting research or RSI itself going through all of this, what would you, if you had to pick one, what would you say?
I think conducting research, just because since this is a prospective trial, and like we've talked about, it is so hard for pharmacists to get involved in things on this big of a scale. That just getting the opportunity to see all of the inner workings and not only have those conversations with the providers of this research study to, optimize how are things going, that whole just developing those relationships and learning kind of the ins and outs of things we can do, things we can't do, like that whole thing. It was just an awesome experience, as well as seeing the aftermath of, finishing enrollment and all of the communication that goes into getting the manuscript ready for publication and submitting. Like, there were so many people in those emails, it was hard to keep up sometimes.
And right at the time you're in emergency medicine, so I know that that is not a specialty conducive to being up to date every minute on your email inbox as well.
Yeah, yeah, no. My email has never been under control, so I've accepted that as just a fate. That's just not going to happen.
I tell everybody this, it is electronic mail, not emergency mail. So the
Yeah,
idea that, I get a following up in 24 hours after an email, we got to set boundaries there.
yeah.
All
You
right.
probably need to text me and call me.
Yeah,
Come find me in
exactly.
person is probably even
Exactly.
better.
100%. All right, we got to end with this, right? You mentioned you're still sort of team ketamine. So, what do you what do you think questions still need to get answered as it relates to sedatives, sedative use, or even just pharmacotherapy and RSI in general?
Yeah, I think the big one for me is the risk of adrenal suppression with etomidate clinically relevant. I think that's kind of the biggest thing that we're still a little undecided on, because it is the waters there are so muddy.
Yep.
Yeah, so that would be like the next thing for me that I think, maybe start to sway my opinion one way or the other. But yeah, that's where I would like to, see a little bit more clarity on this topic.
Well, Kristen, congrats again. What an awesome accomplishment, contribution. And of course, thanks for taking time to share kind of the other side from a pharmacist perspective into research, kind of letting us know what it was like. This was so fun. Appreciate you. And thanks so much.
Thank you, Nick, for having me. I appreciate it.